Good evening, everybody. My name's Helene, and I've also got Jade alongside me, and we'll be running the webinar on behalf of the PHN and Kidney Health this evening. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to elders past and present. So welcome to tonight's webinar. It's run by Westvic in partnership with Kidney Health Australia. For participating in this webinar, you're entitled to a 20% discount when purchasing a copy of the CKD Management and Primary Care Handbook, which is available from the shop on the Kidney Health website. There's details on this in the chat section as well. There is also 50 free fact sheets to support people living with kidney disease. There is more information in the chat section, so just have a look in there and you can download some literature from that as well. And there's information on how to claim that discount bonus. For this evening, participants will be put on mute for the course of the meeting, and should you have any questions, could you type them in the questions box and I'll ask them on your behalf. They'll be anonymous, so as they come in, I'll just let the presenter know and we can address those when that happens. A quick PHN update. A communique to all general practices across our PHN gets sent out twice monthly, and in this is a calendar of our internal events and a calendar of external events. The majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel. I will now hand over to Joe from our Health Pathways team, who will give you a brief overview of the health pathways relating to this topic, and we will then go directly to our presenter, Dr. Karen Dwyer, nephrologist, to commence the presentation. Thanks, Joe.
Thanks, Helene. Hi, everyone. My name is Jo Rose, and I'm the Health Pathways Programme Officer at Western Victoria Primary Health Network. I'm going to provide a brief introduction to the suite of kidney disease-related pathways on the Health Pathways website. For those of you who are unfamiliar with Health Pathways is an online web portal designed to support health practitioners in the assessment, management and referral of their patients. It contains many locally agreed condition-based guidelines and specific information about local services and how to refer to them. It is an online tool designed to be used by a GP or primary care provider at the point of consultation. You can see on the slide that we have relevant clinical and referral pathways. These have all been developed by local GPs in collaboration with local specialist physicians. Each referral pathway is inclusive of both public and private services in each region of Western Victoria. We have also provided the login details on the slide. This is a generic login that can be used for all of your healthcare team. The site is password protected as it is intended for health practitioners only and not designed to be accessed by the general public. If you have any questions about the pathways on the slide or anything else regarding health pathways, you can use the feedback option, which is the blue icon on the bottom right-hand side of each pathway on the website. Alternatively, feel free to email us at healthpathways@westvicphn.com.au. Thank you.
Welcome everybody. Thanks for coming tonight. And my session tonight is on the early detection and management of chronic kidney disease. My name's Karen Dwyer. I'm a nephrologist practicing locally and also do general medicine. And I'm also the deputy head of the School of Medicine at Deakin University. Just some disclosures that this slide deck has been prepared by Kidney Health Australia in consultation with PEAK, and as mentioned, this is run by the PHN. I have no other speaker disclosures to reveal. And just before we get started, just to highlight the updated handbook, the CKD Management in Primary Care Handbook released this year with the associated app. And just some of the things to take note from the new guide is the hypertension targets, which we will refer to in the talk. A little bit of information about CKD hotspots, which is areas within Australia where there's higher prevalence than the general prevalence of chronic kidney disease, and this is across Australia and all in all states. There's a sick day plan, which is particularly relevant, and we will touch on that again in the webinar tonight with some medications to be particularly mindful of. Managing chronic kidney disease in the presence of diabetes and cardiovascular disease, which is a very common scenario for individuals that you'll be managing. And then there's some expanded information which would also be very helpful to be able to look up. So the aim for tonight is to look at tools to drive the early detection of CKD in a primary care setting. And our learning outcomes will include the importance of early detection for those at risk of chronic kidney disease, the elements of an assessment for chronic kidney disease, and some of the treatment options to delay progression of chronic kidney disease. So as we get started, just as a reminder, what is chronic kidney disease? And it refers to a reduction in the eGFR, the glomerular filtration rate, that's been present for about 3 months or so. This may be in these, also in the setting of some albuminuria, hematuria. There may well be some structural abnormalities or other pathological abnormalities. It's an extremely common condition, and the overall prevalence in Australia is 1 in 10, so about 10% of Australians. But of course, as I just mentioned, it does vary widely across the country, with a very high burden of disease in Indigenous patients, particularly in the Northern Territory, and also across the various states and within the states. So if we look within Victoria itself, we actually have some hotspots within Victoria where the prevalence is as high as 12.5%. Chronic kidney disease is very common, and probably not widely appreciated that it's twice as common as diabetes. But of course, diabetes is very, very closely linked with chronic kidney disease, and as we'll touch on later, is the most common cause of end-stage renal failure, at least in the community. And whilst 1 in 10 have evidence of chronic kidney disease, we know that 1 in 3 Australians actually have risk factors for chronic kidney disease. But most people, most of those 1 in 3, will not know that they're at risk for chronic kidney disease. So as I just mentioned about diabetes before, this is a figure from the ANS data, which is a big registry that records all patients that commence renal replacement therapy, whether that be through dialysis or via transplantation. And we record quite a lot of demographic and other data on these patients. So it's a very robust and useful registry. But from this, we can see that the primary cause of end-stage renal failure and commencing renal replacement therapy in Australia is diabetes. Diabetes constitutes about 38% in non-Indigenous Australians, but once we move to Indigenous Australians, it's closer to 70%. The other major cause for renal disease, chronic kidney failure, is high blood pressure. And then there's other factors such as glomerular nephritis, particularly something like IgA nephropathy, polycystic kidney disease, which is the commonest genetic cause of kidney failure in our community. So as I just mentioned, for those that receive renal replacement therapy, the most common cause is diabetes, and followed by hypertension. But as you can see from this figure, and the numbers are actually quite old now. This is from 2013, so we could certainly magnify these numbers a lot. But the concept still remains, is that the graph that I just showed you before is the peak of the pyramid, or the top of the iceberg, and below this is the many thousands to million of people that are at risk of renal disease due to the high prevalence of hypertension and diabetes. And as we'll go through, as we move through the talk, I hope it will become evident that although a significant number do progress to end-stage renal disease and require renal replacement therapy, many of these people don't actually reach the tip of the iceberg, because they die beforehand prematurely from cardiovascular disease. So why do we need to detect chronic kidney disease, and why detect early? Primarily for the reason I've just highlighted, that it is very harmful and there's this very high risk of cardiovascular disease. So it's really one of the strongest risk factors for coronary artery disease, and it's more potent a risk factor than diabetes. And if we break that down further, and I'll show you a figure shortly, it's for both the drop in eGFR, but also the presence of proteinuria has a very significant impact on cardiovascular disease risk factor. cardiovascular risk. CKD has significant impacts on work, family, psychological well-being. When somebody's on dialysis, for example, it significantly impacts their ability to work, for example, and the psychosocial impact can't be underestimated. The risk from cardiac death is very significant, and across all age groups, there's a 2 to 3-fold greater risk. That's encompassing all age groups, but if we actually stratify for every age, at no matter what age, the risk is far greater. And in fact, the younger you are with renal disease, the greater your risk of cardiac death compared to an age-matched control. So, you know, if we've got someone that's in their 20s or 30s, their risk of cardiac disease is close to 100-fold that of their counterpart that doesn't have renal disease. And thinking about the impact of renal disease, around 65 Australians die every day with kidney disease, which is more common than many common cancers such as breast cancer and prostate cancer. So this is what I was referring to earlier about the risk of chronic kidney disease and then the risk for cardiovascular disease. And so this work has now was established in around 2004. So we've been aware of the link for some time now. But as we, if we look at this figure, and this is for cardiovascular mortality, and similarly for end-stage renal disease, you can certainly see the pattern is quite similar, with the eGFR along the x-axis, and as we move to the left, we've got a drop in eGFR, and then the adjusted hazard ratio on the y-axis. If we look at the biochemistry, so as an eGFR drops below 60 mils per minute, we can see that there's this exponential rise in cardiovascular mortality. And similarly, if we look at for end-stage renal disease, as the eGFR drops below 60, it really takes off in terms of risk. The colours here are proteinuria. So blue is no proteinuria, green is microalbuminuria, and red is macroalbuminuria or overt proteinuria. And you can see as you develop proteinuria and it increases in quantity, that risk magnifies further again. And so this is quite important because it gives us a target in terms of reducing proteinuria, for if we can move someone from the red area to the green area, you can see there's quite a significant drop in their risk for both progressive renal disease and also cardiovascular mortality. So it's the combination of protein in the urine and the biochemistry that forms the basis of our kidney health assessment, and that really is founded on this risk of both progressive renal disease and cardiovascular mortality. So it's important to know about renal disease and to try to detect it early. And why is that? Is that we can, it is treatable to a point. There are things that we can implement to try and slow the progression of renal disease, and there has been some fairly significant changes in the last couple of years on approaches to trying to slow the progression of chronic kidney disease. The other important aspect of identifying renal function early is to detect the complications that can arise with renal disease, and these things are quite readily treatable, such as anemia due to renal disease. The anemia due to renal disease can really impact someone's quality of life and are actually relatively straightforward to manage and can be managed quite early. Mentioned before that a lot of people that have chronic kidney disease are unaware that they have the disease or are a risk factor or have the risk factors for renal disease. And despite the uniform eGFR being reported, there is still a lot of, it's still relatively common for people to be referred quite late to need renal replacement therapy. And that's obviously a complex scenario, and it's often a very difficult thing for the individual who has chronic kidney disease to come to terms with. So if we move along to the elements of assessment for chronic kidney disease, I've really alluded to these being a blood test for an eGFR and a urine test assessing for a urinary ACR or urinary albumin creatinine ratio. Just to read a little bit about why we now report with an eGFR, and I'm sure everyone can remember that the serum creatinine that used to be the sole report for renal disease is a very inaccurate marker for, very insensitive marker, I should say, for renal disease. And if we look at our GFR, our glomerular filtration rate on the x-axis, and again, as we move to the left, it's reducing in number. If we get to our 60 mils per minute, a serum creatinine, which is represented on the y-axis, is still within the normal range, and so you essentially can lose half your renal function before you may see a rise in your serum creatinine, and so that immediately puts someone in that very high risk category before we're getting the alert biochemically that there's perhaps some issues at play. Whereas the automatic eGFR reporting enables detection of people with an eGFR somewhere between, say, the 60 and 90, so that we know that it's certainly not in that dangerous zone that we saw before in terms of the risk for progressive renal disease and cardiovascular mortality, but it tells us that it's not normal. And this may be particularly important, for example, if there's someone relatively young presenting and would perhaps alter our management, may not so in an older population. It really depends on the patient context. So the eGFR is important and does allow us to detect renal disease earlier, and we've covered most of this, but just to reiterate, the importance of that is to reduce that cardiovascular risk. So certainly with eGFRs that are in the 50 to the 60 mils per minute, I'm perhaps less worried about progressive renal disease, again, context dependent and age dependent, but I'm certainly very attuned to the increased risk from cardiovascular disease that now befalls that person. Reduced morbidity and mortality, the morbidity associated with some of the complications. Again, the anemia is something that is relatively easy to manage and can have a significant impact on quality of life, to slow progression and prevent complications. So just with the eGFR, I mentioned that the serum creatinine is not specific, and it is important to realise that the eGFR, it's a pretty complicated equation, but certainly serum creatinine is part of that equation. So although it provides increased granularity, there are still some limitations to the eGFR, and they are listed here. So in the setting of an acute change in kidney function, we tend not to report with the eGFR, but use the serum creatinine, or we might, for example, talk about a doubling of serum creatinine. It's not very useful when someone's on dialysis. We know that these people really they have very little eGFR, and so it doesn't provide a great utility when someone's on dialysis. Because serum creatinine is influenced by much of what we eat and drink, so extremes in dietary intake, for example, can really influence someone's serum creatinine as well as their hydration status, so that may well influence the eGFR. So an example might be the bodybuilder, for example, and then someone perhaps on a vegan or vegetarian diet. Extremes in body size can influence the eGFR, as well as diseases of the skeletal muscle, and if we think about an amputee, for example, who loses a significant component of creatinine in their muscle, their eGFR will be less accurate. In children under the age of 18 years, when there's severe liver disease, it can be complicated. There's drugs that interact with creatinine excretion, and so, for example, if someone's put on trimethoprim, we expect to see a rise in the serum creatinine, and that's a function of the medication and will resolve. eGFR is very useful, but it's less accurate when it's above 90 mils per minute. Now that's at the very far right-hand end of the graph, and is relatively pretty normal function. So it's less concerning than if it was less accurate, perhaps in the middle range where we really need it to be accurate and in pregnancy. eGFR and drug dosing. though it's valid to use the eGFR to assist in drug dosing. As you know, many drugs need to be altered with reduced kidney function and can impact kidney function, and it is acceptable to use the eGFR for drug dosing. But of course, if you have drugs that have a narrow therapeutic index, then they still obviously need to be monitored very closely. And it's also important to not appreciate that there's lots of drug interactions. And so, for example, with a renal transplant recipient, we do need to be very careful about drugs that might interact with immunosuppression, which then may well impact their renal function. I mentioned before the urine test, so a urinary ACR or urinary albumin-creatinine ratio. And so this is the recommended test for screening for proteinuria. A urinary ACR can be done as a spot urine test. Excuse me, it can just be done as a spot urine. If that is normal, as in if the ratio is not elevated, then that's fine. If the ratio is elevated, then it needs to be repeated, and it should be repeated on a first void specimen. The reason for that is that it's a physiological response to excrete some protein. So, for example, if someone had been for a run, particularly a fairly long or intense run, they may well have a degree of proteinuria in the urine as part of their physiological response. So, if we do a first void specimen, we know someone's been lying down overnight, they've been sleeping. They shouldn't have physiological proteinuria, which would be complicating the interpretation of that result. So, a spot urine's fine. If you do repeat it, try for a first void so that at least you can see whether that was a false positive. And we would say you've got albuminuria if at least 2 out of 3 urinary ACR tests are positive. So you have a high ratio, and we'll talk a little bit about the ratio in a moment. Dipstick analysis is no longer recommended for screening. And the main reason for that is the poor sensitivity and specificity. So when a dipstick is positive, you've usually got at least 0.3 grams per day or 300 milligrams of protein in the urine, which is in that macro or overt albuminuric range. That means we're missing that microalbuminuric range, which, as I showed before on the graph, is very important in terms of stratifying for risk. So a urinary ACR is the way to go. And so the ratio that we're looking for is normal is less than 2.5 for men and less than 3.5 for women. The difference reflecting the difference in creatinine excretion due to size. And the microalbuminuric range is therefore between 2.5 and 25, 3.5 to 35, and then the overt macroalbuminuric range is greater than 25 or greater than 35. The question about when to use a urinary ACR or urinary PCR often comes up. The urinary ACR is the screening tool, and I find that once you've got your result, it's easier to keep it as a urinary ACR so you can compare. But you can see that the differences aren't huge, and so it's neither here nor there really in terms of which one you would like to use after you've done your screening tool. The important thing if you wanted to try and convert that to the amount of protein per day, a rough rule of thumb is to take your ratio and divide by 100. So for example, here our ratio is 25, divide by 100, that's 0.25 grams per day. So roughly 300 or 250 milligrams per day. And so that just gives you a little bit of a guide as to what this ratio might mean in terms of timed urinary protein excretion. So if we're thinking about someone that might have nephrotic range proteinuria in the setting of diabetes, they may well have a urinary ACR that was 4500, so 4,500, 450, I should say, 450, let's divide by 100, they got 4.5 grams per day. And certainly in nephrotic syndrome, we can see very, very high ratios. I guess the other question that comes up is, well, that's not that accurate, and it's not, but it gives us a general feel of where the amount of protein might be. We used to, in the past, do timed urinary protein collection, so the 24-hour urine collections, and I would say they're also not very accurate, as we often would have someone not collect the first sample or the last sample, and you know, it's probably, it lacks the sensitivity and specificity as well. The other thing I would say is if you've got someone that's got significant proteinuria, if they've got 2 grams or 3 grams, if they really have 2.2 grams or 3.5 grams, it doesn't really matter. It's giving us a ballpark of how much protein they've got, and if we use the ratio to compare as you manage that, and if you can see that ratio falling, you know that their risk for renal disease, progressive renal disease and cardiovascular disease is also falling. So it's really the trend that we are trying to ascertain, not the absolute specific number. So in terms of thinking about treatment options to delay progression of kidney disease, the number one target for us is blood pressure. So, management is blood pressure, and that's very important for slowing the progression of renal disease. The target for chronic kidney disease seems to, the goalposts do seem to move a bit. At the moment, the goalpost is at 130 on 80, and that perhaps is a little bit at odds with some of the other hypertensive guidelines that have come out, particularly ones that have come out from the US, where the target is 120 on 80. And so I think the important take home here is to really be individualising your target blood pressure to your patient. There are other comorbidities. Do they have significant proteinuria? Do they have concurrent diabetes? There's lots of factors to take into consideration. But 130 on 80, I think, is a really good target to be aiming for. The other thing just to think about is that blood pressure and chronic kidney disease are very tightly linked. So chronic kidney disease can give rise to hypertension, but as we showed before, hypertension can also give rise to chronic kidney disease. So it does become a really vicious cycle, and hence the importance and why management of hypertension really underpins the management of chronic kidney disease. In terms of what agents to use, we've now known for a long time that the use of ACE inhibitors or angiotensin receptor blockers really underpin the management of someone with chronic kidney disease, and in particular if you've got someone with diabetic kidney disease. We know that it has effects on blood pressure, it has independent renoprotective effects, and it has the anti-proteinuric effects. So there's been lots and lots of trials now that show that introducing ACE inhibitors or ARBs does slow the progression of renal disease, and it does reduce the degree of proteinuria. The key for initiating these agents is to initiate early, and as you know, the way it works is to drop the pressure across that glomerulus. So we do expect to see a change in renal function as a function of the drug actually working. So my rule of thumb is when I start an ACE inhibitor or a angiotensin receptor blocker is to check renal function 5 to 10 days later, about a week later, and I will accept a 20% rise in serum creatinine. More than that does make me concerned about underlying renovascular disease. Now, of course, again, this all needs to be done in the context of each patient. If I've got someone that has evidence of vascular disease, if they've got renal bruits, for example, my index of suspicion is going to be much higher than if it's someone that doesn't have those particular risk factors. But the take-home message is to use ACEs and ARBs when we can, and to start to try and initiate them early to slow the progression of renal disease. But I do think it is much easier to manage that change in renal function that you will expect if you're initiating, for example, with an eGFR of 40 mils per minute than when you're initiating with an eGFR of 20 mils per minute, which does make things pretty complicated. The new kid on the block, and this is where something has changed in renal medicine recently, is the SGLT2 inhibitors. Now, the SGLT2 inhibitors have been around for a little while now, and obviously were marketed for management of blood glucose as an oral hypoglycemic agent. But as you're all aware, the impact of the SGLT2 inhibitors, particularly on cardiovascular outcomes, was far greater than what was expected, considering the lipid lowering effect that they have, which is relatively modest. What we've also seen is that the SGLT2 inhibitors have quite a marked effect on renal function and preservation of renal function. And there have been a number of trials now, starting with the EMPA-REG, but also Canvas, and most recently was Credence last year. And Credence actually used engaged patients that had a somewhat lower eGFR. You can see through this analysis that the protection from progressive renal disease is certainly favours the use of SGLT2 inhibitors. Just like with ACE inhibitors, when we start the SGLT2 inhibitor, we expect to see a change in renal function, so an increase in serum creatinine, which we then expect to see will plateau. And once again, these slow the progression of renal disease or slow the decline in eGFR. So again, these are things that I think, if possible, we try to introduce early, because the earlier we can get these medications in, the greater the effect with slowing the progressive renal disease. So this is the most recent data that's come from SGLT2 inhibitors and renal disease, and this is the DAPA CKD trial just recently published. These figures are sort of similar across all the various papers that have now been published, is the SGLT2 inhibitor versus placebo, and lower composite outcome measures, and when we break this down into renal specific composite outcomes, greater protection with the SGLT2 inhibitors. There's been the different SGLT2 inhibitors that have been utilised in these trials now is across the board. So this is probably a class effect, and so that's useful, because not all of the SGLT2 inhibitors in the trials are available in Australia, but it does look like a class effect. So they're probably the two tips, is to get these in as early as possible when able to. And so that's really a bit of the background, and now we'll go through a case and certainly build a little bit more information into the narrative as we go. So this is a case of a 63-year-old woman called Rita, who's an accountant with a history of mild asthma, and she's new to the practice. She has a past medical history of being overweight with a BMI of 31, the mild intermittent asthma and chronic low back pain, and a history of mild hypertension. Her maternal grandmother died of a heart attack in her 60s, but also had a history of kidney problems. Mother has type 2 diabetes, and father has angina and hypertension. So a little bit more about Rita. She's a smoker, 20 to 25 cigarettes per day, giving her a 25-pack year history. She has 1 to 2 glasses of wine 3 to 4 nights per week, no known allergies, and her only medications is PRN Ventolin. So we have a number of polls that are scattered through. I think there's maybe 4 polls that are scattered through the rest of the talk, and so we're at poll question 1. So if you could just click as to whether you think Rita has an increased risk of chronic kidney disease. We're just waiting for all the numbers to come in. So once they're in, it'll move on. So just press a yes or a no.
Hi Karen, it's Jade from Western Victoria Primary Health Network. 100% results are in. I'm sharing that on the screen now. 100% have said yes.
Oh, okay, great. I can't see that part, so that's good. Excellent. All right, so great. So, yep, she does. And as I mentioned before, 1 in 3 Australian adults are at increased risk of chronic kidney disease. The risks reflect the causes of renal disease, so diabetes and hypertension. So that's reasonably straightforward. There's a bidirectional relationship between cardiovascular disease and renal disease. So if you've got established cardiovascular disease, you're very likely to develop renal disease, and vice versa. I've already shown you the evidence for chronic kidney disease as a risk factor for cardiovascular disease. And I think with established cardiovascular disease, just think about the blood vessels, the vasculature of the heart is affected, and they're connected to the the arteries that feed into the kidney. So you will have the same atheroma, for example, that's building up in the heart will also build up in the renovascular tree. If there's a family history of kidney failure, and this is important, if you've got someone that has a family history of kidney failure, it does increase the risk of kidney failure in the subsequent generation. And it doesn't really matter what the cause of that renal disease was. So, for example, if Rita's, I think it was her mother, had renal failure due to IgA nephropathy, that puts her at risk of renal disease, even though she may not have IgA nephropathy, but she has got diabetes. So the family history is important. Obesity is an important risk factor for renal disease, and obviously this then becomes a target for managing renal disease. And another way of slowing renal disease, tied in very closely with managing hypertension, is weight loss and reducing that body mass index. Being a smoker is a risk factor for renal disease, and as you can see, there's a huge overlap. The same risk factors for cardiovascular disease we see for renal disease. Being age 60 or older. Acute kidney injury, and this is just another important one to be aware of, that a history of acute kidney injury, even if you get full biochemical recovery, does increase your risk of developing chronic kidney disease, end-stage renal disease, and death. So this is just an important one to be aware of, because we have a lot of people that spend some time in hospital, and acute kidney injury in hospital is very, very common. If we walk into an intensive care unit, possibly at least half, probably 3/4 of the people in intensive care will have an element of acute kidney injury. And as I mentioned before, there's a huge burden of renal disease for Aboriginal and Torres Strait Islander peoples. So Rita has 4 of the risk factors. So yes, she is at increased risk of chronic kidney disease. So just a little bit about diabetes. I mentioned before that diabetes is the commonest cause of people needing renal replacement therapy, around 40% for non-Indigenous Australians, up to 70% for Indigenous Australians. If we think about all the people that have diabetes, approximately 30 to 40% of those people will develop diabetic nephropathy and then progressive renal disease. And everybody is aware that we've got a huge number, or we've got a tsunami really of diabetes coming through, and the figure there of 1% of adult Australians are developing diabetes every year. So one would expect we're going to see a lot more people developing renal disease, unless we can really stop renal disease and diabetes in its track. So just a little bit about diabetes. I mentioned before, this is a modifiable risk factor, and one that I think, I certainly perhaps need to pay more attention to in terms of trying to minimise progression. So it's a bit similar to all the other graphs. Once we hit a certain point, we see that the risk actually really takes off. And so once someone's above overweight, so into that obesity category, we do see the risk of renal disease take off. Interestingly, if we were to biopsy people with just obesity, for example, as their risk factors, we can see changes in the kidney, a direct result of obesity, so changes happening within the glomerulus. So if you can lose weight, then those changes can reverse. So it does really show that there is a bit of flexibility in our physiology, and it's certainly an important area to think about and to try and help manage. Talked also about the smoking. I don't think this would be of any surprise to anyone that with smoking we get an increased risk of vascular disease, we get an increased risk of kidney disease. Poll number 2. The elements of a targeted assessment for chronic kidney disease in at-risk groups. So Rita's turned up. What are the important things? You've identified that she's at risk for chronic kidney disease. What are the important things to do now?
Okay, most people have voted, so we'll roll with that. 94% have selected option 1, 19% option 2, 88% option 3, 29% option 4, and 88% option 5.
Great. Okay. All right. So what we would recommend in terms of screening for these to assess Rita is a blood test looking at the eGFR in particular, a urine test to look for the urinary ACR, and then of course a blood pressure measure. So this is kind of the little package to have with you for screening a patient and then for following patients. So for example, if I have someone with IgA nephropathy that I am keeping a watch on every 6 months or yearly, the parameters that I look for at each visit: serum creatinine, blood eGFR, blood pressure, and protein excretion. So what would you do next? We've recognised that Rita's at risk and that she needs the kidney health check. If her results are negative for chronic kidney disease, she needs to have a kidney health check each year. She's over 60. She has a number of risk factors, so we would recommend a yearly check, and with those 3 parameters. And depending on the number of risk factors, it may be every year or it may be every couple of years. So for example, if Rita was just age that was her risk factor, then that might be something that you do every 2 years, for example. If her blood pressure, for example, is well controlled. So we've gone through this. We need a blood test, we need a urine test, and we need a blood pressure check. So that's quite a nice visual, I think, there. So we do these investigations, and this is what we get back. We have a serum creatinine of 118 micromoles per litre, with the normal for this lab being less than 115. That calculates to an eGFR of 55 mils per minute. Greater than 90 is usually reported, because we remember that the sensitivity above that is not great, so greater than 90 is reasonable. We have a urinary ACR that's 5.7, and for women we are aiming for less than 3.5, and her blood pressure is 155 on 95, and our target is 130 on 80. So poll question number 3. Does this mean she has chronic kidney disease? We have yes, no, or not yet.
Thanks, Karen. 67% have said yes and 33% not yet.
Great. All right, so we say not yet because like with most conditions, we usually need to have the test repeated and confirm that it is abnormal over 3 months or more. So we've been through this just as a reminder. If that urinary ACR was a random, then we would a random urine, a spot urine, we'd get that repeated with a first void specimen. We do look for 2 out of 3 urinary ACR tests to be positive or to be elevated. When the initial eGFR is less than 60, just think, could there be something else that is impacting that reading on that particular occasion? Was she on antibiotics, for example? Was it trimethoprim? Was it, had she been unwell for some other reason? Was she dehydrated? What's her diet like? You know, is there something else that could be contributing to that number? But then, you know, we need to confirm it. We've briefly mentioned about why to repeat the urinary ACR, so just some other things to think about. There could be an infection. One would hope that there would be some symptoms that would point us in that direction. We might see proteinuria with heart failure in an acute febrile illness. Again, this is a physiological reaction. We talked about heavy exercise, genital discharge, and drugs may also contribute. So Rita comes back in 2 months later, and we will repeat those tests, urinary ACR, eGFR, and we take the blood pressure. And now we've got the 2 sets of data. eGFR is at 52 mils per minute, the urinary ACR is at 8.4, and blood pressure 160/95. So fairly similar to the first occasion. So now Karen, what's the next step?
I've just got a quick question, Karen. Is it better to do a CR level and ACR in a non-fasted state?
Sorry, is it better to do a urinary ACR?
Is it better to do a CR level and ACR in a non-fasted state?
Okay, so not necessarily. So I certainly don't specify that to my patients. If someone was, you're right, in a fasted state, that certainly, you know, if they get, you know, some dehydrated, volume depleted, that may impact their numbers. But as a general rule, it does not matter. So I don't specify. All right, so what is your next step? So now we can say, I'm just going to go back one, because we've now got sustained abnormalities over a couple of visits, and we can now start to think about what's happening here. We've got an eGFR that is below 60. So if we remember our graph below 60, that risk is starting to take off. So this is important to know. We have a urinary ACR that is greater than 3.5, which is what we're aiming for a woman, but it's less than 35. So it's in that microalbuminuric range, and we have a blood pressure that's certainly above our target. This is the staging for chronic kidney disease, and I quite like thinking about where someone fits into this graph. So Rita has an eGFR 52 to 59, I think it was, my short-term memory's gone, mils per minute. So that puts her into this range here. So that's stage 3A, and she has evidence of microalbuminuria. So the first column is normal, second column is micro, third column is macro. So we just go along here to macro. She falls into this category here, so into an orange box. And the importance of the orange box, that will then help you with your management plan. And why I quite like this is it really does show the risk of progressive renal disease and cardiovascular disease, with green being everything's fine, yellow is low risk. So in this, there's a very slight increase of chronic kidney disease, slight increase of cardiovascular disease here. But as you move into orange, that risk increases, and now we're into red. We've got very high risk of both progressive renal disease and cardiovascular disease. So it's a nice image, I think, to have in your mind as to where someone falls in this grid, and then what their risk would be. So we think that she has stage 3A with microalbuminuria, which is the way that I would sort of categorize Rita. And then we can move to the orange clinical action plan. So I think this is quite nice, and this will give you some tips and tricks as to what to look for, what to think about in terms of managing someone with this degree of renal impairment, and it becomes more complex certainly as the degree of renal impairment progresses. So here is a little bit more about that orange clinical action plan. And it gives you some ideas on how frequently to review this person, some of the things to keep an eye on. So yes, the blood pressure and things that could really make a big difference is the smoking and the weight. If we could help her stop smoking and help her reduce some weight, that would have a really significant impact not only on blood pressure but on her renal function. And then some lab tests just to be keeping an eye on, and we've got the ones that we know about now: the urinary ACR, the eGFR, the biochemical profile, so that's our U's and E's, hemoglobin A1C obviously for someone with diabetes, with their lipids and FBE, the calcium and phosphate. This is important for renal disease, and potentially at that sort of level at 55 mils per minute, it'd be unlikely to be seeing changes in calcium and phosphate, but certainly as that progresses, you may well start to see some changes in calcium phosphate and therefore in PTH. And as I say here, it's often below 45 mils or less. And then this is again something else that potentially we can assist in managing and hopefully prevent renal bone disease and fractures and whatnot. There's some other good things just to think about. Probably a good time to think about avoiding nephrotoxic medications, so anti-inflammatories, and particularly now that these can be bought over the counter, a word of warning for people about anti-inflammatories. So as the general practitioner, how do you reduce the risks of cardiovascular disease? So cardiovascular disease, hopefully, I've said it a few times now, but hopefully it's stuck that it's a really potent risk factor for cardiovascular disease, far more potent than diabetes, and yet we don't sort of consider it a traditional risk factor. People are far more likely, I showed you that pyramid before, or the iceberg, you're far more likely to die of cardiovascular disease and actually reach end-stage renal failure. And so because of the very high risk factor, you don't need to ascertain their cardiovascular risk. You don't need to go into the cardiovascular tools to see if they've got high risk, because we know that they have a very high risk for cardiovascular disease. So you don't need to use the calculator. So we've talked also about blood pressure reduction. This is really the underpins all of renal medicine is blood pressure control. So that's the emphasis needs to be there. So for Rita, the targeting her weight, the smoking would be really important first line goal therapies to be, or strategies to introduce. I'd introduce the ACE or the ARB early as a first line therapy. We now do not combine ACEs and ARBs. Once upon a time we were, but more recently it's become clear that the profile of combination therapy is not great, so we don't. And particularly if someone's got proteinuria, I really do try to push to the maximum doses of the ACE inhibitor or an ARB. So that's certainly important. If it's more blood pressure that I'm targeting, that's when I might introduce a combination therapy a little bit earlier, because we know that that's quite potent in reducing blood pressure. And as I mentioned before, I'd also be thinking about her glycaemic control, and can we get an SGLT2 inhibitor, which, because of its diuretic effect, does have an effect on blood pressure as well. And our target, less than 130 on 80. We've talked a little bit already about kidney function. When we introduce the ACE inhibitor or the ARB, we do expect to see a change in renal function. So less than sort of I sort of like about 20%, 25%. I've even seen up to 30%, but sort of around that 20% I'm reasonably comfortable with. Much more, everyone gets a little bit twitchy, so it's probably best just to watch that, and also be careful of the potassium, of course, because obviously potassium goes up.
A question, Karen.
Yep.
Just one question. At what level of eGFR would one expect PTH to become abnormal?
So it does vary from person to person, but it's unlikely when you've got an eGFR, I would say, you know, certainly above 40 mils per minute. It's earlier, I think we would tend to see a bit more anemia before we see changes in the calcium and phosphate balance, and therefore PTH. But it's at more advanced renal disease. Having said that, you certainly can get it a little bit earlier, but it tends to be sort of around that 40 mils or below. Just a little bit hypertension. This isn't news to anyone. I don't think that if we can move the blood pressure from these numbers that are certainly not uncommon, 160 on 95, down to our target, we can see the big reduction in the big improvement in eGFR that we can, or the slowing of the rate of loss is a better way of saying it. So it's quite important. The analogy I use for patients is it's like a hammer and a nail, and that the hammer is the blood pressure and the nail is our kidney. And if the harder we hit it and drive that into the wood, we just want to be tapping. We just want to really tap that kidney or tap that nail. So we just want a very light blood pressure. So try and get that blood pressure down. The comorbid or the concurrent cardiovascular disease is extremely high, and so therefore we do need to look at the other parameters that are amenable to therapy. So lipid lowering if possible. Ideally, if we can do that through diet, it's probably better than introducing more medications, but sometimes we will need to use lipid lowering therapy and glycaemic control. And just to reiterate, the use of SGLT2s when we can. Self-management, I'm sorry, I just realized that we're getting close to time, so we're just going to whiz through these. Self-management, like with all chronic diseases, we really need to be empowering our patients for them to be actively involved in the management of their conditions, actively involved in trying to make those behavioural changes, for example, around smoking cessation and weight loss. And for the lifestyle modification, I'm sure you're all aware of the importance of all of these parameters. So stopping smoking, trying to reduce BMI, alcohol, physical activity, weight reduction, and a particular diet for diabetes for hypertension is the DASH diet. This is, I think, a really useful thing, just as in the last couple of minutes, is to think about when someone's sick, particularly so if someone's got chronic kidney disease, they're more at risk of having an acute kidney injury. And as I mentioned before, if you have an episode of acute kidney injury, you're more at risk of getting chronic kidney disease. So if you've got someone that's got chronic kidney disease and they have pneumonia or they have a gastrointestinal illness or something like that, they can become dehydrated. I say to patients, you really just don't have that reserve. So if you've got chronic kidney disease, some other intercurrent illness may just impact that renal function a little bit more, and it's really then important to think about the drugs that people might be on. So the sulfurs, so if you've got a change in renal function, a drop in renal function, you may not excrete your sulfurs, so you might get prolonged hypoglycemia. In the acute setting of an acute volume depletion, stop the ACE inhibitor, stop your diuretics, that will make things worse. Acute changes in renal function with metformin, the risk of lactic acidosis, ARBs, just like with ACEs, anti-inflammatories. I think everyone knows that you get volume depleted acute kidney injury, we don't want a triple whammy, for example. And the SGLT2 inhibitors, very much like metformin, and I use the same sort of action plan as I do with metformin. So get them to stop if they become unwell.
Just a couple of questions.
Yep.
SGL2 treatment, why does it increase creatinine?
So it's a factor of the way the SGL2 inhibitor works. So it is excreting sugar into the urine, so you get a diuretic effect. So part of it is loss of weight, loss of fluid, which will change renal function, and you do get also a drop in blood pressure. So again, it's that drop across the glomerulus. So what we see is a change in renal function early, reflecting those acute hemodynamic changes, and then things stabilise.
And the next question, does exercise alone improve kidney function?
Does exercise alone improve kidney function? So probably indirectly, I would say yes, because we know exercise alone has profound effects, for example, on blood pressure, and positively impacts blood pressure by a reduction. It causes, it has lots of immediate effects with regards to glucose metabolism and insulin sensitivity. So indirectly, I would say yes, it does.
Thank you.
All right, so I actually can't remember how many more slides, but hopefully not too many because we're just over 8. But if we can be really quick with this poll, in your practice, who gets referred to a nephrologist? Everyone with CKD, everyone with CKD and diabetes, CKD and hypertension, rapidly declining kidney function, patients who need to start dialysis soon. And there's obviously more than one correct answer there. We could move on, I think, for that.
No worries. So 38% said response 1, 8% response 2, 8% response 3, 15% response 4, and 31% response 5.
Great. Okay. All right. So just of those, so not everyone diagnosed with CKD would necessarily need to come to a nephrologist, and not necessarily if CKD and diabetes, but certainly if there's, or with hypertension, but certainly if there's somebody that presents and they're at their first presentation. So if Rita, when you had confirmed, had an eGFR of say 30, you certainly might send her along because she's got quite advanced disease. If someone's got rapidly declining kidney function, definitely, and if they need to start dialysis soon, I think it's always better to be cautious. So if you've got concerns, best to refer, and then hopefully it's a matter of reassurance that this is what we need to do moving forward. So it is important to refer because it does help with reducing the rate of progression of end-stage kidney disease and then associated morbidity and mortality. And one of the most important things is getting that preparation for renal replacement therapy. So getting them prepared for something like dialysis, or hopefully going straight for transplantation. There's nephrology guidelines there that you can look up in the book, which will also give you some guidelines, which is nice. We've already talked really about the parameters that we're targeting. So a blood pressure less than 130 on 80. Albuminuria, we really want to try and get it low, low, low. So if we can get it into a normal albuminuric range, that's terrific. But every increment drop has a positive effect on that hazard ratio for renal disease. And as tight glycaemic control as we can, and better still if we can get some reversal and really improve glycemia with lifestyle modification. All right, our treatment targets and therapy choices do have to be individualised and personalised for each person. So these are they're broad guidelines, and then we really have to tailor it to the person in front of us. It is important to be looking for some of those complications which can really impact quality of life. Certainly anemia, for example. The avoiding of nephrotoxic drugs, non-steroidals are the big one because they're over the counter. Just watch for those ones, and then refer on when you've got a question or would like some input. So in summary, it's really common. CKD is common, it's harmful and it's treatable. Early detection is beneficial. We've gone through some of the risk factors, and remember, just urinary ACR, eGFR and blood pressure. That's our three tools, and we aim for a low blood pressure if possible. The Red Book, or the CKD management book, is really very useful. Lots of good information there. And yes, a lot of patients can be managed in general practice, but then, you know, we're always here for advice if that is needed. So refer on if you think you need. And there's the book that you can get with the app, and some further resources. And there's information on the Kidney Health Australia website. Shilpa's a nephrologist from Adelaide, and she's wonderful and does lots of beautiful presentations. And as I mentioned at the start, this has really been prepared by the Kidney Health Australia and Peak. All right, so thanks very much for your time. I apologise we're 7 minutes over, and I hope everyone has a good evening.
Thanks, Karen. I'd like to take this opportunity to thank you very much. That was a fantastic presentation. And for the attendees, if you could please fill out your survey, and you will get your CPD points as well for this presentation. And thanks again, Karen. I'm sure we'll see you again for another presentation. Bye,
no problem.
everyone.
Thanks for your time. Okay, bye-bye.